Howdy everybody, my name's Jonathan. Welcome back to your MSK unit, and today we are continuing to talk about one of the terminal branches of the brachial plexus, the axillary nerve. So if you're ready, let's hop into it. Before we get into our slide, I think it's a good idea to go over our brachial plexus roadmap and talk about how we get to the axillary nerve from the nerve roots. So C5 and C6 are going to join together to form the superior trunk. From there, they'll send off a division to the posterior cord, where C5 and C6 will branch off again to form the axillary nerve. As I just mentioned, the nerve roots of the axillary nerve include C5 and C6. I think it's worth mentioning that this does not include the C5-C6 biceps tendon reflex. Even though they share the same roots, the bicep is innervated by the musculocutaneous nerve, not the axillary nerve. So this means that you can have a normal intact biceps tendon reflex even with axillary nerve damage. All right, let's move on and talk about the motor innervation of the axillary nerve. The first muscle we'll talk about will be the teres minor muscle, which is this right here. So the teres minor muscle is going to originate on the lateral aspect of the scapula, and then it's going to insert on what's called the inferior facet of the greater tubercle of the humerus. The important part to note is that the greater tubercle is on the lateral aspect of the humerus. So this teres minor muscle needs to reach around the humerus in order to insert on that inferior facet. So you can imagine that when this muscle contracts, what we're going to have is a rotation of the humerus, and so we will see external rotation of the arm. Additionally, because of the scapula's location, it'll also cause a little bit of adduction of the humerus, pulling it toward the body. And the other muscle that's innervated by the axillary nerve is the deltoid. This muscle here. The deltoid is named after its triangular shape and is often broken down into three parts to help distinguish the different origins and actions that the deltoid contributes to. For instance, the anterior part of the deltoid originates on the distal part of the clavicle and then inserts onto the humerus. And so you can imagine flexion of this part of the muscle will flex the arm in front of the body as well as abduct the arm up. In contrast, the posterior part of the deltoid, if this part is contracted, then the arm will extend behind the body in addition to abducting up. The medial part of the deltoid is going to originate on the acromion and then insert onto the humerus and be a big contributor to the abduction of the arm. Together, the parts of the deltoid are going to contract together to abduct the arm at the shoulder when it is greater than 15 degrees. For the first 15 degrees, the supraspinatus, the small muscle in the shoulder girdle, will be the primary abductor of the arm. As we approach and exceed 90 degrees of abduction, other muscles like the serratus anterior and trapezius muscle will contribute to arm abduction. Because the axillary nerve innervates the deltoid, when there's axillary nerve damage, sometimes we can have deltoid muscle wasting. And this leads to something that we call a flattened deltoid. And so this looks exactly what it sounds like. There's a sort of flatness on the side of the shoulder due to atrophy and muscle wasting from axillary nerve damage. All right, let's talk about sensory innervation. So the superior lateral cutaneous nerve will be coming off the axillary nerve to innervate the lower shoulder and lateral arm. And so one way I like to think about this is that the fibers of the deltoid are going to go along and they're going to insert here at the humerus. And so the axillary nerve is going to have to innervate all these fibers, and then it's left here, this spot on the arm, and it goes, well, now what? We've already innervated the deltoid. I might as well innervate the skin while I'm here. And so the area of the skin that's innervated by the axillary nerve is just below the insertion point of the deltoid. All right, and finally, let's go over some causes of injury to the axillary nerve. And something to consider before we talk about specific causes of injury is where is the axillary nerve located? So it's innervating these muscles and the sensory that's very high up in the arm, near the top of the humerus or in the shoulder. And so any damage to the upper humerus or to the shoulder can present with axillary nerve damage. So a common way that there may be axillary nerve damage is with an anterior dislocation of the humerus. Anterior dislocations constitute about 90% of all dislocations of the shoulder. Importantly, let's talk about what an anterior dislocation of the shoulder looks like. So a patient will come in and their injured arm will be externally rotated and abducted away from their torso. Additionally, a fracture at the surgical neck of the humerus, which is up here, can sever or compress the axillary nerve. Like any nerve in the brachial plexus, compression from a tumor or iatrogenic causes can compress or damage the nerve. Specifically, a shoulder surgery, maybe after a dislocation, can damage the axillary nerve. All right, let's do a recap together and then we'll do a practice question. So the nerve roots of the axillary nerve are going to come from C5 and C6, forming the posterior cord and then forming off to the axillary nerve. The muscles innervated by the axillary nerve will be the teres minor, this muscle here, which will reach around the humerus to externally rotate the arm in addition to adduction, and the deltoid, this muscle here, which will work to flex, extend, and importantly, abduct the shoulder above 15 degrees. The sensory innervation of the axillary nerve will be at the lower shoulder and lateral arm around the area where the deltoid inserts into the humerus. And causes of injury include anything that can damage the upper humerus or shoulder, including a dislocation, a fracture at the surgical neck, compression from a tumor, or a surgery mishap. And a practice question might sound something like this. A 75-year-old female presents to the emergency department with intense shoulder pain after a fall. Vital signs include a blood pressure of 139/99, a temperature of 37 degrees Celsius, and a heart rate of 98 beats per minute. On physical exam, the patient has a shoulder that is internally rotated and adducted. X-ray shows anterior dislocation of the shoulder. What are the nerve roots of the nerve that is most likely injured in this patient? So as we discussed earlier, an anterior dislocation of the humerus is a common cause of axillary nerve damage. And if you'll recall back to the beginning of the video, we talked about the nerve roots, which is C5 and C6. All right, y'all, that's everything from me. Good luck studying, and I'll see you next time.